so we're going to cover some more, I guess, miscellaneous criteria here. Some of these are STEMI mimickers, so they're really good to know. And some of them are just helpful things that you might come across in the field. So here we go. First one right here. Just going to start by taking a look at it. Just want you to maybe pause it for a second, take a look at it, see what you think. I'm going to give you a second to pause and seconds up. So let's take a look. You have some ST elevation in here. Okay, hope you kind of noted that. You've got it in V3 and V4, right? Now, question stands, is this a STEMI, right? This is one of those things that gets a lot of people. First of all, how is your patient presenting? So this particular patient has had chest pain some in the past, very mild, very intermittent, didn't sound cardiac in nature, more like a musculoskeletal thing, but still complained of chest pain, right? So we're still going to do that 12 lead to be sure. Was not currently experiencing chest pain at the time, okay, that this ECG was taken. So we're going to look at a couple factors here when we're evaluating this 12 lead, because this is EBR right here, early benign repolarization. Hate to spoil it for you, but when looking at this 12 lead and looking for this criteria, we're going to first look at their age. This person is 22. Not impossible, but highly unlikely that they're suffering from an MI, right? Not impossible. I will reiterate that. Not impossible, but highly unlikely. They are less than 40 years old. All right. And then it brings us to this question of the ST elevation right here, because early benign repolarization means that just that repolarization begins a little bit early, right? Hence the thing. And it's benign, so it's not significant. Even though some of the research now is kind of stating otherwise, I'm just telling you that's where it got its name. They didn't think it was anything, no big deal, whatever. And then so here we have it. At least I think the research is. I have to look it back up again. But either way, morphology on this particular QRS is a concave, less than 3.5 millimeters of ST elevation. So what does that mean? Well, I'm going to draw some lines here. And I'm drawing the lines for this particular criteria. The bottom red line is the isoelectric line. The top red line is the 3.5 millimeter cutoff, right? So as long as we're below that top line, we're like okay as far as this criteria is concerned. Okay, so it's elevated, but not like a huge amount. And then it brings us to this concave morphology, right? This concave shape, and what that means. If you drew a line from the J point to the peak of the T wave, okay, from the J point to the peak of the T wave, you will find a concave shape. So it's underneath the blue line. That's what that means. It caves in, right? Concave. You can imagine that it's like half of a smiley face, right? And if I drew the smiley face to the left, that's my smiley face. So it's benign. It's okay. It's not so good. Generally speaking, when you have like pathological ST elevation, you'll make a convex shape. So it pops above the blue line there. But that, again, that's not always the case. It's just kind of one of those things that you'll find there. But we do have this particular morphology in this 12 lead. It's concave. We also have a very prominent concordant, talked a lot about that one in the last one, concordant T waves. Okay, so very big T waves, very prominent, very easy to spot, essentially is what we're saying here. And that kind of covers a lot of the big stuff with early benign repolarization. It's a very common STEMI mimicker. Okay. And again, zooming that out, looking at it again, we can see those shapes in V3 and V4. We don't see any reciprocal changes as well. Again, I know I didn't cover this too much in some of the last videos, so I'm going to kind of recover it again. What is a reciprocal change? Well, it's collateral damage, right? So if we have this vessel that's occluded, the tissue in that area dies, and then that death, if you will, kind of spreads outward to other areas, and it does so in a very kind of particular pattern. So reciprocal changes would mean if I have elevation, or if I have damage in these inferior leads here, I would see damage, if you will, kind of being done. So generally that means if you have ST elevation in 2, 3, and AVF, you'll have ST depression in the lateral leads, right? So 1 AVL, V5, V6. That's usually what that means. It's not 100% thing. It's not something I would take to the bank and like go on every single time, but oftentimes you might see that. So, and they're paired. So if I do have ST elevation in the lateral leads, I'll have ST depression in the inferior leads. That kind of thing. And then, of course, that leaves the anterior septal leads. Their reciprocal changes can only be seen with a posterior 12 lead, so V7, 8, and 9, because it's on the backside. We're talking about the left anterior descending and the left circumflex there going around to the back. So those reciprocal changes you won't even see unless you do a posterior 12 lead. So good reason to do it, But that's really benign. So STEMI mimicker, again, taking the context of the situation in here. They weren't having chest pain at the time. They weren't diaphoretic. They weren't altered mental status. They weren't all these things at the time this 12 lead was taken. So even though they met 2 contiguous leads of 1 or more millimeters of elevation, got to use some common sense here. And one of the things a lot of people ask me is, what's that little bump after the QRS? You'll see it in different forms, like, in V5, it's kind of a little bump. V6, you'll see it. Even in lead 3, you kind of see this diagonal downward. We call that a J wave. In this particular case, you'll see it sometimes in EBR. It's kind of a thing you may find, but you also may have it in hypothermia. Some other significant things. This person was not hypothermic, but just that's what that is. If you're asking what about it, so sometimes you'll see J waves there. Not a big thing in this particular case, but just something to be aware of there. Now, let's take a look at this in practice. So you've got this 12 lead here, ECG override. So we're going to have to manually do this thing. A lot of EBR, calling it EBR depends on the context of the situation that you're in. Got to read your patient. That's really super important. So this particular patient was just electrocuted, mildly, might add there. And, is the elevation here significant? Did the electricity mess up his heart? Did something bad happen? So like a lot of artifacts here, mess you up, but, look at the age, younger patient, not complaining of any chest pain right now. How did he shock it? He shocked it by plugging something in to the wall outlet or an extension cord and, just got his fingers in between and got a little zap. So, nothing significant. But, this is EBR. He wasn't having a STEMI, but you do see the concave shape in there. You do see the elevation in there. That fits a very classic thing. A lot of times you got to look for some particular things in the patient's background will say that they will make it likely that they have it. But a lot of times like hypertension or something like that, those kinds of things could lead to EBR. So now this next one here is a little bit more subtle. And so what I'm looking at here are the T waves. If I'm looking at what's striking me here, it's the T wave. Now he's got some ST elevation here. This is a respiratory distress patient, and he's got T wave inversion pretty much everywhere. Now, one of the big things, or sometimes you'll hear this criteria with it being pretty much a respiratory call, right? This is a respiratory focus on this particular call. Is S1Q3T3, which basically means I've got I've got, so S1 in lead 1, I've got an S wave. Okay. Q3T3. So I've got a Q wave in lead 3 and an inverted T wave in lead 3. And they say that this criteria would indicate a pulmonary embolism. Now, I will state that the numbers would reflect that about 7% of confirmed pulmonary embolism cases have this particular change. So very, very small percentage actually display this. But what 83 or 87%, I can't remember the statistic, of people with confirmed pulmonary embolisms did exhibit T-wave inversions. And that's what we're kind of looking at here. You know, how reliable is this T-wave inversion for the case of, you know, just a lot of problems. If I'm looking at this, you know, this person has a lot of T-wave inversion throughout the 12 lead, which would indicate some kind of global perfusion problem here. And that's kind of one of your bigger signs. Like T-wave should generally be upwards in all these leads, but I mean, it's upward kind of here, even though there's some depression. You know, so that's just one of those things that you hear oftentimes. I just want to put that kind of in frame, that S1Q3T3 and just T-wave inversion in general. So just drawing your attention to that kind of thing. Now, this next particular patient is kind of an example of this, of the previous one we just had, to where you've got, you know, S wave, Q wave, and inverted T waves. You know, is this person having a PE or not? You know, that's super hard to tell in the field, and it's something I wouldn't like bank on in the field. Like they may exhibit it, but you know, there's a lot of other changes in these 12 leads that I would look at. And again, you know, keeping it in mind what your patient is presenting as, respiratory distress, you know, fixing the overlying problem. But just to give you kind of another example of what that may look like out there is this one. So brings me to this particular 12 lead. This person, you know, can't really give us a history, we'll say, for example, right? For whatever reason. What do you notice that's wrong with this particular 12 lead? Okay, just pause it, take a minute, look. Now that you've unpaused it, or just skip forward, let's take a look at what is weird about this one. We have, kind of going back on this theme, T-wave inversion, like some solid T-wave inversion right here, right? Is it significant, you know, based off what the patient? It's hard to tell, like if they're respiratory, maybe it is, maybe it isn't. But one other thing to note with this is this. Look at this. Oh my goodness, look at this. Normally, again, way back when we were talking about axis deviation and stuff, you know, we always tried to find the most biphasic lead, right? But what is up with this? You've got lead 1, lead 2, lead 3 in downward deflections, and AVR and an upward deflection. If I'm looking at this, as far as axis goes, that would tell me like I'm an extreme right axis deviation or something weird, right? Something that doesn't make a lot of sense. Especially, we'll just say, for example, in this particular patient who is not presenting with anything like significant, right? So what is going on here? If this looks weird to you and it looks weird to the situation, it's probably because the leads have been reversed. This is a lead reversal, a lead reversal issue here. So it's one of those things you have to be kind of mindful of. Make sure the left arm is on the left arm, not the right arm. Just kind of putting that in there. And if you know your Einthoven's triangle really well, you'll be able to tell which lead exactly is the one that's reversed. You know, you can impress your friends at parties with that little trick there. But, you know, enough about that. moving on. So again, let's take a look. Let's pause it for a second and just see what's up, okay? All right, now that you've done or not done that, we are going to look here at this particular 12 lead and see what's weird about it. So starting right off the bat, we don't see any elevation really. We don't see anything crazy, but we do see, again, back on this T-wave inversion right here. That's weird. We got some like massive QRSs right here. Very big, very prominent. Whoops. Very big, very prominent right there. So what is the deal with this one? Well, this is a kid. You'll notice that this is a 3-year-old, and inverted T waves in these precordial leads is normal. Okay, for a kid, that's the way it is because of fetal circulation. The way that is, they're more like right side of the heart's developed, so you get this kind of inverted T waves here, and you get very prominent waves because a lot of times there's not a lot of adipose tissue blocking the signal. And again, moving on to another kid right here, we see the same thing. This is a 4-year-old 12 lead, all of which is normal in these particular cases. But when would you do a 12 lead in a kid? We're talking about likelihood. There is cases where you need to do one. If they are complaining of chest pain, just like any other adult, you would do a 12 lead. Now, not musculoskeletal chest pain, but or something that sounds weird, chest pain warrants it. Syncopal episodes warrant it. Some pre-existing conditions may warrant it. There's lots of reasons. Well, I won't say crazy lot of reasons, but still reasons nonetheless to do a 12 lead on a kid. And if you're not familiar with what you should be seeing, it will throw you off, right? It will be weird. So definitely something to kind of note. You won't do it often. So that's one of the reasons why you got to be kind of mindful of what it is right there. And so breaking this down, we have the inverted T waves. We have very prominent QRS complexes here. You'll note that very normal.